Hello everyone, and thank you for joining this webinar about impact and qualitative research. My name is Claire Jinks and I lead the qualitative workstream in the NIHR Incubator for Methodology. Just under 1,500 people have registered for this webinar today, which is an incredible response, and we're really pleased that this webinar is of interest to you. When we did our first webinar last year, we asked participants what topics they would like for future webinars, and impact and qualitative research came out as number 1 in the poll. So in today's session, we'll ask, what does impact mean? And we'll showcase different ways that impact can be thought about, because there is no single definition of impact. Today, we've got 5 short talks focusing on a range of topics, so we hope that there'll be something that resonates with everybody that's listening. And we hope everyone will also find something useful regardless of your career stage. This is the outline of the session today. I'm going to give a brief introduction about the methodology incubator, and I'll give an overview of the aims of the qualitative workstream. We'll then hear from 5 speakers showing different types of examples of impact of qualitative research, and I'll introduce the speakers as we go through the session. We then have a 30-minute question and answer session. Please do post your questions to the speakers in the Q&A function that is available in Zoom. My colleagues, Dr. Rachel Adams and Dr. Evie Germani, will then be looking at the Q&A questions, and they'll be helping to highlight these to the panel later in the session. You can choose questions that you most want answering by using the uplift function. So please do upvote the questions that you most want answering, because they'll then rise to the top of the list. I'd like to say a big thank you to the speakers who've given up their time today to support this event, and also to our colleagues in the NIHR Academy who've helped to organise the event and who are running the webinar for us today. Next slide, please. So I'll start by just giving a very brief overview of the methodology incubator. It's one of 8 incubators, and it was established in 2020. And the incubators were really established by the NIHR to address areas where there is a need to build research capacity at a national level. And so they focus on identifying barriers that exist to building research capacity, and to help suggest and implement, where possible, solutions in a sustainable way. So they're very much careers-focused initiatives. And the aims of the methodology incubator are to increase capacity in research methodology, to help attract and retain people in rewarding careers as researchers and as methodologists, to support the training and development pathway for methodologists, but also to work with the NIHR and other funding bodies to help develop increased opportunities for methodologists to apply for funding for methodology research, so doing research about research methods. We currently have 8 active work streams, and the NIHR has renewed its incubators from 2024, and the methodology incubator is carrying on for another 3 years. We have a new name, the Applied Health and Care Research Methodology Incubator, and you can find out information about the incubators from the website. And you'll be hearing more about those when they start next year. Next slide, please. So you can see here the aims of the qualitative workstream on this slide, very similar to the overall aims of the incubator. Our aims include developing a network of qualitative researchers, identifying challenges to career development, raising awareness of the value of qualitative research, and raising awareness of career development and also funding opportunities. Next slide, please. We have a workstream of 25 members who work behind the scenes to do the activity of the workstream, and we also have 5 subgroups. You can also follow us on X, previously known as Twitter, so the group's name is on the slide. We've received lots of emails recently from people who want to join the workstream, and we're currently in this transition period going from the existing incubator into the new incubator. So we'll be contacting people in the new year when we have a work plan for the next term. Next slide, please. We've developed a methodology researchers network map, and developing networks and opportunities for collaboration were identified as career development needs when we did our first webinar. So please do go on to the website. The web link is on the slides here. Go on, have a look. It's very easy to add yourself, and it can help you connecting with people who either have the same research methods, interests as you do, or even if you want to connect with people who have different research methods. So please do go on and add your details. Next slide, please. So now we turn our attention to the topic of impact and qualitative research. And in this webinar, we do want to get participation from you as we can within this Zoom format. So please do feed your comments, your thoughts about this question. You can put your thoughts about this question into the chat. How can we assess impact of qualitative research? We're really keen to hear on your thoughts and reflections on what you think impactful qualitative research is and how we can assess impact from qualitative research. Next slide, please. Okay, so we're going to move on to a live poll. This is just going to take a minute or two. We really want to hear from you how confident you feel in describing impact from your research. So we're going to launch the poll now, please. And it will only take a few minutes. Have a look at the question. How confident do you feel about describing impact from your research? And there are a range of options from not confident at all, a little confident, confident, fairly confident, or completely confident. So we'll just take a few seconds just to complete the poll. And we should be able to see the results of that. Be able to have a look at the results of that in a minute. How confident do you feel about describing impact from your research? Okay, we can share the results of the poll. Thank you. So hopefully you can see the results of the poll there. So we've got a range of responses from not confident at all, 21% of people, a little confident, 52%, confident, 18%, and then fairly confident, 9%. Okay, so thank you for completing that poll. So I'd now like to move on to the main part of the webinar. So I'd first like now to introduce our first speaker, Professor Carolyn Chu-Graham, who's a GP in Manchester and a Professor of General Practice. Carolyn's going to talk about the impact of qualitative research on general practice. So I'll hand over to Carolyn for her talk. Thank you.
Thanks. I'm just checking, can people see my slides on slideshow? Will somebody give me a
I'm
nod?
afraid we're on full view. We just need your slideshow view, please.
So I have tried to share it. So this is a slight problem.
It is sharing. It is sharing, Carolyn. It's
okay.
Just you're not in slideshow.
Right. Okay. So just trying to get rid of stuff from the top to.
You can do that on the bottom right.
There we go. That should be it.
There you go. Brilliant.
Hopefully that's it. Okay. So. Thanks very much, Claire. And I'm going to talk about the impact. I'm going to try and talk about the impact of qualitative research on general practice. I am a GP in Manchester and also Professor of General Practice Research at Keele University with a particular expertise in qualitative methods. Claire's asked me to do this in 10 minutes. I've got quite a few slides, so I'm going to race through them. Do feel free to put stuff in the chat or Q&A. I'm sure that most of us here know what qualitative methods are. We as qualitative researchers investigate the how and the why. We try and gain a wider understanding, either by talking to people or by observing, talking face-to-face, or perhaps over the last 3 years, we've been talking to our participants online or by telephone. And we end up with some transcripts, which is our data, and we create meaning out of that data. And being a GP, I will have a particular stance bringing to my interviews, but also to the analysis and the meaning I create. So qualitative research enables us to develop concepts, and we try and understand and give meaning to people's experiences and perspectives. But what's impact? Well, Claire asked that question and people have been putting stuff in the chat, and it is about influencing or having an effect on a service, a policy, a new product. So I'm going to try in the next 8 minutes to say how I've tried to conduct my qualitative research and demonstrate impact. I think there are two ways, or there's a spectrum, and I'm going to illustrate different ends of the spectrum. So a slow burn, or sometimes, occasionally, we can light the touch paper and get immediate impact. So first of all, the slow burn. 20 years ago, she says quietly, I did a feasibility study developing a new intervention for older adults with depression. This was based in Manchester, and there was some qualitative work going along with that, which perhaps had more impact. We developed from our qualitative work the term normalisation of depression. We said that older adults and healthcare professionals felt that it was justified or normal for older people to be depressed. And we coined the term therapeutic nihilism, that there's no point finding out if somebody's depressed because there's no treatment, both of which are wrong. The qualitative work and also the feasibility study did appear in the NICE Depression Update in 2009. I'm not sure it's made an impact on clinical practice. Took this work forward into a feasibility study of training Age UK support workers to deliver a similar intervention based on the principles of behavioural activation for older adults with anxiety and depression. And just to say that by this time we were doing a lot of patient and public involvement, not just in the development of the study and patient-facing documents, but more particularly in bringing people into the analysis of our qualitative work. So what's the impact of this sort of work? I think it impacted on clinician training, both formal and informal. Some policy documents, certainly in Manchester, the NICE guidance, we mentioned collaborative care, so Notepad, and also the other work 20 years ago got mentioned. And this has formed the foundation of a big strand of my work over the last 20 years. Also important is I've worked with Age UK for quite a long time and often write commentary for Age UK that may be related to my work or may be related to something they're interested in. And I've developed materials for example, the Royal College of GPs, Royal College of Psychiatrists around mental health problems in older adults. I've also taken this work forward into other studies. So we trained community pharmacy staff to develop deliver an intervention again around subthreshold depression, but for people with long-term conditions. Big qualitative study within that, and we found that this was acceptable both for community pharmacy staff, pharmacy teams, and also for adults with long-term conditions. We then took this learning forwards, and I think this is a common theme in qualitative work, that you build on what's gone before. So we got program grant funding for a program of work around refining, developing an intervention for older adults with long-term conditions. Again, lots of PPI and stakeholder involvement, lots of consensus work to refine the intervention, qualitative work with both healthcare providers and older adults. Got this worked up, and then COVID struck. So we thought in March to May 2020, what are we going to do about MODS? Well, we'll change it. We got urgent public health funding, labelling or badging. We did a lot more qualitative work online, a lot more stakeholder work, and repurposed this intervention to a behavioural activation intervention for people who might be socially isolated during COVID. And the impact on Reviewer 2 is given here. This is an impressive effort, as it was organised and run during the first wave of COVID-19. And to think I was just moping around at home in my track pants during the same time period. We've published this work, and I guess we hope that we showed it was an appropriate, acceptable intervention, and we say that it should be considered as a population intervention for people at risk of depression and loneliness. We reported the trial along with a living systematic review. So along with the qualitative work, we feel this has the potential to be cited in NICE guidance, but will there be an update for depression? Will there be a guidance on loneliness? So really, when I think about this work around older adults, I think, gosh, we've built on the learning, we're doing another trial. Where are we going next? This has been a slow burn. We have had sidetracks, so I've been working with Tom Kingston at Keele, and we're looking at the potential for non-traditional providers to identify and support older adults with anxiety and depression. So we've worked with a fire and rescue service staff, but again, it's part of a slow burn. We have developed a blueprint for a new intervention, and we're hoping to get funding to actually test that out with fire service staff. But back to COVID. In May 2020, I became aware as a GP that we were hearing from people who were really not recovering from an acute COVID-19 infection. And so at PACE, convened a research team, worked with patients by experience, experts by experience. We got university ethics approval. And as I was doing that, the term long COVID was named. Lots of PPIE in this, speaking to people, patients in my practice, but also colleagues, discussions on social media. And we advertised using social media for people who felt that they'd been affected by COVID and were continuing to have symptoms to take part in an online interview. You'll have seen these slides before: ethics approval, PPIE, semi-structured interviews, digitally recorded, transcribed, thematically analysed, and again, discussing the findings both with our original PPIE group, but also with the participants who had been interviewed for the study. And this work produced really four main findings, main themes. So participant one talked about the hard work of managing their symptoms. People also talked about the hard work of accessing care, particularly primary care. There was lots of uncertainty, fears about this was a new virus, what's happening. All participants talked about the difficulties they'd had in being believed, about the importance of finding the right GP, and participants talked about what they needed. This study was a real lighting the touch paper. So we got the paper published in October 2020, one of the first papers reporting the narratives of people with long COVID. And it appeared in the NICE guideline in December. So if you look at the key recommendations from the NICE guidelines, believe your patient, listen, acknowledge their symptoms and problems, show empathy. And that's directly taken from our work. NICE suggested that clinicians shouldn't dismiss people with a psychological problem or anxiety, the importance of building trust, shared decision-making, and again, all things that came from our qualitative study. So this impacted on NICE. On the Royal College of GPs, I developed some top tips and a learning module, wrote quite a few articles for BJGP, that's the British Journal of General Practitioners Life, gave lots of webinars across psychological therapies, Royal Society of Medicine, RCGP, delivered training to GPs, clinical commissioning groups, practice nurse groups, developed a long COVID knowledge boost, which we updated in the summer, did quite a bit on return to work, contributed to the commissioning of multidisciplinary long COVID clinics, and got funding for further research on long COVID. So a real like the touch paper study. So what are my takeaway messages? Well, for me, I think research questions should always be grounded in clinical practice. And as a GP, every clinical day gives me questions that I think that would make a good research question. I think my work is centred around person-centred care, and I think qualitative work allows you to do that. I think qualitative work allows you to investigate alternative service models. And I think I've demonstrated that qualitative methods, qualitative research does have value. It's not just a, yes, this works, no, it doesn't. It's a, why might it work? I hope I've demonstrated that impact can be achieved in a variety of ways. But I think also you have to be patient. So generating impact can take time. A lot of my work is slow burn. Occasionally you like the touch paper and things get a lot of traction. You have to be in the right place at the right time, I think, for that. So thank you very much. And any questions?
Thank you, Carolyn. Thank you for that brilliant overview of some of the work that you've done. We've got a Q&A section at the end, so please, participants, please do put your questions in the Q&A section, and we'll hopefully have a lot of questions in the chat, and we'll hopefully come to answer some of yours in the 30 minutes we've got later. So thank you, Carolyn, for that fantastic talk, a brilliant overview of a huge amount of work, and you're already giving me lots of things to think about the impact of qualitative research on guidelines, on responding to key societal issues, and you've provided some really good takeaway messages. So thank you for your talk, and we look forward to hearing you in the Q&A. So we're now moving on to Professor Sarah Shaw. She's Professor of Health and Social Policy Practice at University of Oxford. She's going to talk about using qualitative research to inform policy and practice. So looking forward to your talk, Sarah. Over to you.
Thanks, Claire, and hello, everyone. I hope you can hear me all right. How to follow that? That was brilliant and really interesting, Carolyn. I suspect this is slightly different, and I think because of the nature of policy, perhaps a slightly different take on impact and informing policy and practice. So that's right. My name's Sarah Shaw. I'm a qualitative researcher in Oxford, and I've got a long-standing interest in using research and different kinds of evidence to inform policy and practice. I'm a sociologist by background, and I've been working in and around academia for around 30 years, and very much focusing on the organisation and delivery of care. And I really like to work across boundaries, which is probably why I've come into this field of work. So I like working across different kinds of networks and organisations and with different people and perspectives. Not that that's always easy, I have to say. And I've always held an academic post, but I've also worked elsewhere. So I've worked in one of the Royal Colleges, I've worked in an independent research organisation, and I currently run a new centre, which is a partnership with RAND Europe, which is doing rapid evaluation of technology-enabled remote monitoring. What am I going to talk to you about today? Just very briefly, I want to just turn to what policy and practice are, why qualitative research is relevant, and how to approach doing impact. I then want to just give you one example of work that we did in the pandemic on video consulting, reflect a bit on what worked well, and then also flag actually 7 challenges that we might return to in discussion, whilst appreciating that there are things that also go really well. It's not always challenging, and there may be some more challenges along the way. I'm being very selective and really quite rapid in the 10 minutes, so do please put in the chat and add to what I'm saying as we go along. So first off, what are we actually looking to impact or influence? And it's this question of policy. And so for me, typically when people think about policy, they often turn to this as the policy cycle, and they think about tangible legislation, regulation, or policies that are administered by government departments, like the Department of Health and Social Care. So for instance, the NHS long-term plan. But it's really rare to impact on those kinds of policies deliberately and in ways where you can show a demonstrable change. So it's very rare to get my research on X resulted in a policy on Y, an action by the department on Z. It's really, really unusual. So I like to think of policy in different ways. So consisting of really less tangible elements and things that are including what is being done, but also potential for inaction and things that aren't done. And so this definition from Murray Edelman is really interesting to me because it sees policy as a set of shifting, diverse and contradictory responses to a spectrum of political interests. And I guess I see myself as a bit in the mix of all of those interests. And those perspectives and values and interests, they come from people in government, but they also come from civil servants, professionals, and people on the ground who are also tasked with putting policy into practice. That's what I'm focusing on. So when and why then might qualitative research be relevant? Well, the key point here is making sure it's relevant. And we're working in a time when problems are very much proposed and resolved in the context of application. So there's a really great opportunity here for all of you as qualitative researchers to do applied health research and potentially to inform policy and practice. And I've put up some of the ways in which it's potential to do that with Qual here. So it might be about identifying a policy problem, informing implementation, also thinking about transferability and the way in which interventions potentially move from context to context and spread and scale, understanding what matters to patients, evaluating impact, and down at the bottom I've put dealing with complexity and addressing wicked problems. So those things that are particularly multidimensional or lots of stakeholders, and Qual research really lends itself to dealing with that complexity in ways that quant research really doesn't. And before I get to my example, just to think about how you're looking to inform policy and practice. And this is from a paper by Christina Boswell and Kat Smith, who look at 4 models of research policy relations. And the first thing, these are pretty simple. The first of these is really about knowledge shaping policy. So we do research and then we hope that it might feed into policy or develop some strategies to make that happen. The second one is really the other way around, where policy is kind of fishing out for research. The third one is about co-production and working together through that process. And the fourth one is really about autonomous spheres, where researchers and policymakers are kind of existing in different worlds, and sometimes they kind of collide. It's perhaps a bit more accidental. I'm interested particularly in co-production, and that's what I'm going to focus on today. And I'm focusing on that because I think a lot of the work on impact and informing policy and practice is about relationships and dialogue that can really help to bring about change. So my example is from the start of the COVID pandemic, and it was really interesting to go back to this actually. So as you know, there was all sorts of policy problems floating around in the ether, and one of them was to how to rapidly spread video consulting across the UK at the start of the pandemic, enable physical distancing and reducing the risks of infection. So there was a real opportunity here for research, and we had already done work in this area. And to do qualitative research with policymakers, managers, staff and patients to really look about adoption, but also spread. And that was funded by the Health Foundation that also likes to work in this space and is perhaps a bit closer to policy. What did we do? Well, the aims were to gain an overview of spread and scale up, but also share transferable lessons throughout and generate insights to inform future changes. And this is the kind of data that we had. And a lot of it was about qualitative research, but we did also start with a national survey across the UK, which proved a really useful way into discussion with policymakers, as well as allowing us to sample and do some work with the qualitative data. The really important bit for me here is these 2 aims. They're right up at the outset that we were aiming to share transferable learning and be really formative about that work. So it was built into the study and the funding. We did that through scoping work across the UK. So first off, within a couple of days of talking about the project, we were working with decision makers across the 4 nations and with the funder to get to the right place, talk to the right people and begin to think about what was needed and why. And we began already co-producing the boundaries of the research and those questions to make sure that we had relevance. I also started to build in conversations data, and so we got ethics approval really, really rapidly, and we treated those conversations as part of the qualitative research process rather than just as conversations with policymakers, and that proved really useful in thinking about informing an impact down the line. We also used those relationships to be able to access data, and we used the national survey as a way of opening up opportunities for understanding about adoption and spread. And I guess we built in a really flexible design and a kind of iterative way of working, which was very characteristic of the pandemic, but I think is really important in these kinds of co-produced studies. A word here on thorny issues. So just to go back to the beginning of the study, we were actually asked to kind of go beyond the scope that we wanted to do. And that very much came out of a concern around the digital divide that was emerging at the time, and about health inequalities. And the policy interest at the time was really to get us to look at that in a lot of detail and with different kinds of data. And I think it was really the lesson for me anyway was to be really, really clear up front about what's feasible and possible, and what kind of impact you might be able to have. And what we ended up doing was a really quite basic, but some qualitative exploration and understanding of emerging digital inequality, which has led to much deeper work, but being really clear that the data wasn't available for us to do anymore. I just thought it might be useful to just map out broadly some of the work that we did as we sought impact. How did that actually happen? So we had a kind of multi-pronged approach, which is going to look a bit crazy because it also felt a bit crazy at the time. The study was actually 9 months long in the end in 2020, but as you can see, impact continues, much as Carolyn was saying. Our strategies at the beginning were very much about emerging learning and getting that out as widely as possible. So we used a series of blogs and social media. I was working with Trish Greenhouse, who's lucky enough has got a huge Twitter following, which we used very proactively. And then we set up webinars with policymakers and professionals and patients in some cases on really key issues like workforce, actually some of the access to infrastructure and equipment for video consulting, but also about managing risks with new ways of consulting. And then we had a lot of ad hoc, informal conversations and discussions with decision makers as we went along. And then at the other end, we've got the academic papers which have been coming out over a longer time and much more summative learning. The other thing which I have absolutely loved doing and which has been really important in terms of impact has been working with patients and frontline staff to develop sets of resources from the qualitative research that could support them with implementation and doing video consulting. And I think the value of co-designing those and working with visuals, animations and stories from patients about what worked and what didn't has been really powerful in gaining some of that impact. What happens, very, very briefly, I could talk for a long time on this, but very briefly, I think we've informed policy know-how. So at a time of crisis, when policymakers were really struggling about what to do and how to get spread and scale up, some of the work we did and the formative learning certainly seeped into that process. In terms of how it's actually measured, that's another question we can come back to. We informed implementation at another number of different scales. And then also monitoring and review as the policy process was progressing and getting a sense of the activity was out there, impacting on thinking about training and support needs for staff, but also patients, and directing resources and actions to the right places, hopefully at the right time. I think we supported NHS organisations with those visual resources. They were open access, free to anyone to use and adapt, and that went down really well. And then we've increased the evidence base on video and remote consulting, but also on policy making at times of crisis and what we can learn from that. And just as Caroline, this has also led on to further work. So I'm going to stop there, but I just want to put up 7 challenges really that relate to using qualitative research to inform policy and practice that have really struck me through the research that we're doing. So the first of those is really about, I do think relationships and dialogue are key, but that brings its own challenges in terms of maintaining independence if you want to have impact. Balancing rigour with the kind of rapidity that we've been talking about in fitting with crisis and with policy making cycles. Grappling with transferability and context and spread versus still conversations when you're talking about qualitative research to do with statistical generalizability and people's preferences for that. Using qualitative and other sources of data in combination. So ideally, I wouldn't have done a national survey, but it proved really useful in terms of opening up conversations and opportunities for data in this particular study. I have had some comments back about some of the stories that we've told is they're just stories rather than data. And I think there's a question about legitimacy and how you frame that. And then sharing formative learning that can support policy making and implementation. But how far do you go? You haven't finished yet. So how do you not overstep your analysis and findings when it's really early on? And then finally, I can already see stuff popping up in the chat about measuring impact. We've done a lot of stuff about recording how we've informed policy and practice, or we've influenced certain things, but we haven't been measuring impact. And just as I said at the beginning, we cannot say that this research influenced this policy in this way. I think that's fine, but I will hold off again until the panel at the end. Thank you very much.
Thank you very much, Sarah, for our second fantastic talk there. You've given us a great list of 7 challenges and issues there to be thinking about. And so please do think about those 7 points, and anything that you've heard from Sarah or Carolyn, post in the chat. And that was a really fantastic example, recent experience that we've had through the pandemic, and some really good examples of strategies for impact. So thank you, Sarah. We'll move straight on. Don't forget, we've got opportunities to ask the panel questions, so please do use the chat function, sorry, the Q&A function to post your questions to the panel. So we'll move on now to Professor Louise Lowcock, who's Professor in Health Services Research at the University of Aberdeen, and she's going to talk to us about using qualitative research to inform quality improvement. Over to you, Louise. Thank you.
Thanks. So I'm going to take a different take again, talking more about patient experience research for quality improvement, and with a particular focus on experience-based co-design, which I'll talk to you about in a minute. Oh, page down didn't work. Hang on. There. So why does this matter? Well, we already know a lot from both surveys and qualitative research about what matters to patients about their care, but what do we actually do with that knowledge? It isn't enough just to keep measuring experience and hoping that somehow something will magically change. We need to use that knowledge to improve care. And you could argue that it's unethical to keep asking people to take part in research without actually doing something with the results. So there are roles, I think, for both quantitative and qualitative patient experience data in quality improvement. It can help us assess what experience is currently like, measure if improvement activities are making a difference to that experience, but more also to understand why experience is poor and generate ideas for change. Tell us not just what's wrong, but what good looks like and what could be better. And patients will often give us very simple ideas for change, challenge assumptions and attitudes about what matters, and be a powerful motivator for action and remind us what we're trying to achieve. So you'll see that a lot of those are kind of qualitative things. I'm going to say a little bit more about that in a minute. But first, I just want to show you this example from a study that Glenn Robert and colleagues did, where they had the luxury of having survey data and qualitative interview data from the same individuals. So here's what you get from one data source. This is the survey. Overall, did you feel treated with respect and dignity? Yes, always. Overall, how do you rate the care you received? Excellent. But then from the qualitative interview, this person talks about the thing that does annoy me intensely, the time you have to wait for a bedpan. Elderly people can't wait. If we want a bedpan, it's because we need it now. And then, of course, she wet the bed, and she says it's an embarrassing subject, although they don't make anything of it. They just say, oh, well, it can't be helped if you're not well. And I thought, well, if only you'd brought the bedpan, you wouldn't have to strip the bed, and I wouldn't be so embarrassed. So there's a point there about efficiency as well as the quality of the experience. I'm just hopefully going to show you a clip from one of the interviews in one of our studies that I conducted in Oxford. Mike, who's a nurse manager, talking about dignity in prostate cancer. And while you're watching this, I think you'll see how just even one interview can generate a whole set of ideas and challenges for quality improvement. Come on, Mike. Oh, it's not going to play. No, hang on. Ugh. I don't know why this isn't working. I'm very sorry. I can tell you what Mike says. Essentially, what Mike says is that He was in prostate cancer in very embarrassing positions, and people would come flinging open doors without explaining who they were. And he said, well, I can tolerate that in a dentist chair. It's a bit different when, to put it bluntly, your arse is stuck up in the air. And he also then talks about an experience where somebody, a clinician who he hadn't seen before, came out into the corridor while he was waiting for some results and said, oh, you should expect to see blood in your semen for a while. And he said that meant that the whole corridor turned to look at him, and people saying, oh, well, he's talking about his semen. And he said, I'd rather that they wouldn't do that. And particularly what he talks about is the fact that that's not really a resources issue. It's about culture and training and empathy. And that if we as performance managers, because he's a nurse manager by background, if we stopped allowing that sort of thing to go on, then it wouldn't go on, but we allow it to happen. So moving now to EBCD. So if you've heard of EBCD, apologies if I'm teaching grandmother to suck eggs, but it's a participatory action research approach to service improvement. And local observations and interviews with patients are involved, and you also interview staff, but the patient interviews are on video. And you then use the patient videos to create a catalyst film and have workshops with staff and patients working together as partners. And they look for touch points of interaction where things either have been done very well or where they could have been done better. And then they agree a set of priorities that they want to work on and set up co-design groups which take the work forward. And crucially, it's about equal partnership with patients, family members, and staff. And then they hold a celebration event at the end. Oh, sorry. So experience-based co-design is apparently time and resource intensive because you've got to do a whole load of interviews in each site in order to redesign the pathway in that place. So although it's a very effective model for improving care, it often doesn't get taken up because of the fact that it's so costly and time consuming. So we asked ourselves, what would happen if we did something using nationally derived films rather than collecting local interviews each time? And we called this accelerated experience-based co-design. And we tested it in lung cancer and in intensive care in 2 trusts in England. And what we used was a set of already collected in-depth interviews in the Health Talk archive, which is collected by the Medical Sociology and Health Experiences Research Group at the University of Oxford. And if you haven't seen Health Talk, this is just a screenshot of what one of those sites looks like. It's on intensive care, and the interviews are collected using video, so we were able to make catalyst films. And these are the kind of things that we put on the website that are summaries for people of all the experience evidence that we've collected. So what happened? Well, we wondered whether staff would feel less engaged with patient narratives that have been collected nationally rather than at their particular hospital. And actually, we found it didn't seem to affect staff engagement, and in fact, in some ways, made it actually less threatening, and we got less of a defensive response because it wasn't their own patients up there on a big screen telling them what was wrong with their service. We had one example where one of the patients involved in the co-design events said, oh, this film is too negative. I'll talk a bit more about that in a minute. And that never happens here. We don't have that. Our clinicians are lovely. And one of the clinicians actually saying, do you know what? It does happen, and I have seen it, but feeling more able to say that because it was a national collection. We found a similar sense, as you do in normal experience-based co-design, of staff talking about being held to account through these narratives and reconnected with their fundamental values of care that brought them into the NHS in the first place. So this is a rather nice quotation from a intensivist saying, I can see this person is not only a human being, he's a father, a son, a brother, a friend, he's a cousin, a plumber, etc. He has a dog, he has a budgie, he has plans, he has expectations, he has regrets, he has feelings. So a real sense of reconnection with the humanity of the patient who might in intensive care normally be unconscious in front of you. And one of the staff members involved said, I've already changed the way I think and care for patients, even though we haven't started implementing changes yet. I have a better understanding now of how things are from the patient's perspective. So I think this speaks to cultural change. It isn't just about making single service improvements. It's about changing people's attitudes and reconnecting them with their values. And one of the facilitators in one trust said the absolute core is the humanistic connections. Because of hearing patients, relatives, and staff experience, it acts as a catalyst and gives you energy to keep going and make the change and make sure it happens. So something there about feeling motivated to do the work. As far as the patients were concerned, I mentioned that some felt it was a little bit negative in the film, although in one case, the facilitator said, okay, well, let's listen back to that film again and count how many times people talk about positive things as well as negative. And they were quite surprised how many positive things they counted. We do tend to focus on the catastrophe narrative when we hear things. And actually, people are often telling a much more mixed story where this person was really great. And if I'd been able to show you Mike's clip, you would have got that. But they're just a minority of people who make a difference to your experience. That said, they felt that the films absolutely served their purpose to stimulate discussion and to get ideas going. And they were really very positively surprised at the amount they were able to contribute to the co-design. And people said, I wondered what, if anything, will be taken on board. To be honest with you, everything has been taken on board, and that in itself was a complete surprise. Our views were not dismissed, they were looked at and things changed. And it's kind of sad, really, that most people come into this with an expectation that they won't be listened to. But there's something, I think, about the power of the visual and the narrative that actually makes people listen, makes them stop and think. And just briefly on what happened in terms of the types of improvement activities, they varied across the 4 pathways, but it was very similar in both number and type of outputs to the standard that you would expect in an EBCD project. So there were 48 improvement activities in total, mostly small scale changes, but also some bigger redesign within and across teams, and in one case, a redesign between organizations. And the costs were around 40% of a standard EBCD project once you've taken account of the catalyst film production. So that's just a screen grab of the report that we produced for the NIHR and my usual disclaimers. Thank you.
Thank you, Louise. That was a fantastic overview of a huge amount of work that you've done. Really great insights into impact and quality improvement, evidence-based co-design examples, really nice examples there, and really highlighting the importance of the power of the visual in the narrative. Really nice phrase there for us to take into the Q&A. Thank you very much for your talk. I'm sure you've generated lots of questions, so please do continue to put your questions in the Q&A section, and we can bring that into to the panel later. We need to move on quickly. We're going to change focus a little bit now. So we've heard already about impact of qualitative research on general practice, on policy, and on quality improvement. We're now going to shift to thinking about impact in a different way, thinking about impact in the context of the research excellence framework. So we do have, just before we start with our next speaker, we have a second of our live polls. So I think, Harriet, if you could put the second poll up, please. Thank you, that's really helpful. Hopefully you can see the poll on your screen now. So this question, just one question here, how would you rate your knowledge of, it should be of REF impact case studies, so the Research Excellence Framework impact case studies. How would you rate your knowledge of REF impact case studies? And we've got a range of response options there, from very poor to poor, unsure, good, and very good. We'll just leave that poll running just for a few more seconds. How would you rate your knowledge of REF impact case studies? Okay, thank you. So we have the results of the poll. So 31% rating their knowledge very poor, 33% poor, unsure 21%, 12% good, and 3% very good. That's really great. Thank you for completing that poll. So we're moving on to talk about REF now, the Research Excellence Framework, and this is the UK's system really for assessing the quality of research in UK higher education institutions. And the last REF was in 2021. I'm sure many of you will have been involved in that. Institutions submit REF impact case studies, and I think there were over 6,500 last time case studies across multiple units of assessment. So these are the units that get assessed, and examples that might be familiar to your work are Unit Assessment 2, which is public health, health services and primary care. Unit of Assessment 3 is allied health professionals, dentistry, nursing and pharmacy. And then Unit of Assessment 4 is psychology, psychiatry and neurosciences. So researchers, institutions submit examples of impact in a unit of assessment that's relevant to them. And I'm delighted to introduce Professor Krisha Jejits to tell us more about REF and impact. Krisha is the director of the Impact Accelerator Unit at Keele, has a lot of experience as being on a REF panel to tell us more about what impact means in the eyes of REF. Over to you, Krisha.
Thanks very much for that introduction, Claire. And just to say, I'm giving this presentation very much on the basis of the lived experience of going through these research excellence frameworks. So we know the government hosts these or sort of delegates to the institutions this research excellence framework as a way of judging their return on investment for funding spent on research. And in the last exercise in 2021, impact was 25% of the overall attribution of the evaluation. So it has been now an embedded part of what that looks like. So the impact from research they're looking for is submitted on an impact case study. It's a formal template. It's about 4 pages long, and I'll talk a little bit about examples of what that looks like. So it kind of gives a very structured view of what the impact of your research has been. Next, please. So the overall plan is to really define impact from this very precise research excellence framework perspective, and from my view of my interpretation. I will touch on what was the research excellence exercise in 2014, and I have used that interchangeably. I called it REF 2014, but essentially it's what happened in 2014. Talk about what happened in 2021, and then sort of touch a little bit on what we might expect coming up in 2028. And I've got here the statue by Henry Moore that's owned at Keele University, and just that's to remind us that that there is a science and the art. So once you're writing a case study for this particular exercise, it's going to be reviewed on the whole by academic panelists and those who are passionate about impact. So any interpretation can be a scientific exercise, but it also can be a little bit of an interpretation. So, you know, if you're expecting a Picasso and you're passionate about Picasso, and this case study is looking a little bit like a Henry Moore, you might be disappointed. But if you're passionate about Henry Moore and you get this wonderful example, then you may feel that, you know, this is a really strong case. So next slide. So we've heard a little bit about this, and in impact terms for the research excellence framework, it's defined as an effect, change or benefit to a whole range of very broad dimensions, but it's beyond academia, and that's how it was defined in 2021. So it can be on the economy, on health, quality of life, policy, services, but it is that absolute change, benefit and effect that you're trying to demonstrate. Next slide. So in impact terms for the research excellence framework, it's defined as an effect, change or benefit to a whole range of very broad dimensions, but it's beyond academia, and that's how it was defined in 2021. So it can be on the economy, on health, quality of life, policy services, but it is that absolute change, benefit and effect that you're trying to demonstrate. Next slide. So the criteria against which that it's judged is reach and significance, where reach has got a specific definition, and it's really talking about the extent to which people or others have benefited. So it can be very broad and diverse in terms of all the different dimensions that you will have seen in the previous slide. So it's not only not about geography essentially, but it can be about, you know, the range of those who may benefit. But then there's also this idea of significance. So that is looking at how detailed and how deep is the impact. And so that might be only a narrow focus on one of those dimensions, but really extent to which that the impact has been measured. Next, please. So in from the Research Excellence Framework in 2014, the panel's reviews actually gave us an idea about what was high scoring and what was low scoring. And so if we look at what was low scoring, these were cases or descriptions that really lacked objective evidence. It was superficial, it was vague, and there was a focus on dissemination without actually explaining outcomes and the so what. So it didn't move on to actually determining the impact. So on the counter side, you know, if you've got very clear evidence, the impacts are fairly defined in terms of who's benefiting, and the descriptions are tightly described, and there's a very clear relationship between the impact and the research. And it goes beyond dissemination, then that's leading us to more of a high scoring case. Now for scoring, they do it in starriness. So the top score is a 4-star, and that's world leading. So this is really outstanding. And then it goes 3, 2, 1. So you're going from being internationally excellent, recognized internationally, nationally recognized, and then you can be unclassified if there is no link at all, and there's absolutely no sort of true impact that's judged from your case. Next slide, please. So Justina Bandeler-Gill and Catherine Smith did an evaluation of the case studies that were in REF 2014 to see what the narrative looked like, and they found 4 distinct narratives in the way impact made a difference. Next, please. But what they really identified was that the whole process of actually putting that narrative into a template had moved us from what would be an open and unrestricted format that we usually associate with stories and narratives into a very restrictive storytelling. And what was interesting, I think they commented that the heroes of the story were actually the academics, not the people using it, not the GPs, not the managers, not the patients and the public, but actually the academics. Next, please. So in terms of the 4 themes of impact, they were problem solving. So your impact in your research in some way had an impact on solving problems for stakeholders. It could be building tools. It could be reframing what was already known, and public engagement. But they went on to say that public engagement actually scored the lowest of those 4. And it seemed to be because it had difficulty in fitting into this restrictive narrative storytelling format. So for public engagement, it was described, impact was more on the learning and enlightenment, which was sometimes difficult to translate into the specific quantified and monitorized impacts that participants believed assessors were looking for. Next, please. So in 2021, the sub-panels were encouraged and welcomed public engagement, that it was assessed equitably, and that case studies describing impacts through public engagement, either as main impact or as one of the facets of wider engagement, was welcome, but it was still expected to demonstrate both reach, either through the audience range or participant figures, and significance. Next, please. So what I've tried to do, and I've looked in one of the units, and it's actually not a health unit, it's Unit of Assessment 20, Social Work and Social Policy, to identify what I perceive to be from the scores that are in the public domain on the Ref 21 website is a high quality, maybe 4-star case that does talk about qualitative research. So I'll talk a little bit about what the components are of a case study. So firstly, there's you've got your title. So here's the title: Affecting Policy and Practice Change in England to Improve the Educational Outcomes of Children in Care. So what's really nice about this is that you've got everything that you're about to read is on the tin. The title gives it away. It's nice and descriptive, and you see that. So one of the components of a case study is really a summary of your research and your impact. And I've only drawn out one sentence from that. It's 100 words normally. So, and what they've said here is research has changed the narrative of policymakers in discussions about the positive effects of state care on the lives of separated children. So maybe this case comes in the reframing element of impact. So following that, there's an opportunity of several hundred words to talk about your research. And you can use up to 6 references to actually evidence your research. And the element I've picked out here is that the work was funded by the Nuffield Foundation, and it was mixed methods, and it was multidisciplinary, and it was joint research. So those are some of those features. So the qualitative interviews complemented quantitative results, but highlighted factors that were absent from national databases. So what they learned was those who made good educational progress were those where they felt safe and secure where they were living, that their birth family problems were managed and contained, they were looked after and taught by individuals who genuinely cared about them, and could cope with their individual circumstances and problems at school. So here you've got the research, and they had, you know, lots of other research as well, up to the 6 references. So then the next component then is, well, what's the impact of all of that research? And again, I can't give you all of the narrative on that. And you can use up to 10 pieces of evidence to give the evidence of the impact. But I've just picked up 2. So one was an editorial, and this editorial said that this work was a landmark. It blew apart the prevailing simplistic assumption that because the attainment of children in care is much poorer, the system is letting them down. And then another bit that I've picked out, again, that was evidence, was the change in narrative culminated in a party election manifesto. We will review support for children in need to understand why their outcomes are so poor and why more support they might require, what more support they require in and out of school. So again, and then there would have followed the 10 pieces of evidence of the impact that was described. So that's a very quick and truncated case as it was in 2021. Next, please. So we're now moving, you know, it's like a 7-year cycle, so we're moving towards Ref 2028, and it's out for consultation. So anything that I might now say is really, you know, what we're gleaning from the conversations and the consultations that are currently ongoing. So they have reduced the numbers of case studies for small cases, and they've combined this engagement and impact together. Next slide. And so just to finish, really, what I've tried to do is just give a bit of a sense of the research excellence framework and this narrow lens of how we're judged on the impact of our research in terms of REF. Thanks very much.
Prisha, thank you. That was a brilliant overview. There is so much related to REF, and you've managed to give us an overview in 10 short minutes. So thank you for giving us that overview, telling us a little bit about the restrictive storytelling angle and the issues and challenges around that, and giving us an example from one of the units of assessment, which was a fantastic example. And it's great to hear that. That's from one unit of assessment. We're going to move on to Derith's talk next, and she's going to showcase some more examples that will complement what Krisha's just been outlining. So Derith is a research assistant working in the Impact Accelerator unit at Keele University, and she's been doing a pilot study funded by the Methodology Incubator, looking in a bit more detail so we can add a little bit more to what Krisha's just already been starting to illuminate for us. She's digged a little bit deeper into how qualitative research and methods-based research, so research on research methods and qualitative research methods, are captured and described in REF impact case studies. So over to you, Derith. Thank you.
That's lovely. Thank you very much, Claire, and colleagues on the team who invited me to be involved in this study over the summer. Next slide, please. So really just to capture the aims, as Claire says, of the pilot study, which was to look at the 2021-22 REF submission impact cases for 2 units of assessment, 2 and 3, to have a look to see what the methodology and the scope of the impact of qualitative research methodologies were. In particular, at the same time, we were going to pick out some good practice examples, looking at the application of whether it was an innovative method or an application in a new way of an existing method, and also to identify some observations or any other feedback that might be useful as part of the REF consultation. Next slide, please. So how did we go about it? The team met a few times and we decided that we were going to download all of the case studies in units 2 and 3. So that was 544 from the REF database. We had quite a detailed discussion around the search term of how we were going to refine a subset of data. And we plumped for searching on the word qualitative, which identified a further 157. However, there were a few issues with that, which I'll come to later on, and we know that we've missed some qualitative studies within this sample. Resources was an issue as well, so we decided we'd do 50% of the 157, and the method that we used was, it was an Excel spreadsheet, and we used a data extraction template, which again had its challenges and good things. So we extracted data over the summer for 78 case studies, and we've done some analysis, and we're sharing today some of the preliminary findings with you, and hopefully this will inform the future incubator work. Next slide, please. So on the data extraction template, these are just the data items we had on Excel. So of course, unit of assessment, what was the title? Did it mention methodology? What type of methodology or method? And particularly then, was it new, an innovation, or an application of an existing method? We're also interested to know whether it involved patients in the public. And again, the whole focus of today's discussion, with lots of talented presenters before me, was around how are the impacts measured, and can we make a link between the method and the impacts specifically of the research? And again, the impacts were grouped into categories, and then we made other observations on the templates. Next slide, please. So preliminary results. So of the 78 of the studies, we found that, up to 50% of them were in some combination of either quantitative RCTs, qualitative studies. There were, however, though, at least 30% of studies that were predominantly qualitative, which again was really, I think, a good sign actually in terms of trying to tease out the groupings of qualitative studies and the impact that they specifically have. The remaining really fell into the categories of evidence synthesis. There were 4 there of quantitative, which I think alerts you to the fact that searching the REF database using the term qualitative doesn't always encompass all the types that we were interested in. So that's a summary of the overview. Next slide, please. So a little bit more detail here for the 2 units of assessment. You can see the sample size there of 16 and 62. Really good news was that there was a very explicit outline of the methods, which was a relief to me as a relative novice. And actually, when we started to look at, whether these were developing new methods, qualitative methods, or whether they were using existing methods, you can see that around 30% in both the units of assessment were developing new methods of qualitative approaches. We also looked at whether they involved the PPIE, and really good news, I think, is to see that predominantly lots of the studies did. And this is very broad ranging from quite micro detailed patient level involvement right the way through to macro, collaboration with public sector networks, expert patient panels, the whole range there. One of the things that I found particularly interesting was that of the 2 units of assessment, there was the most common category was slightly different. Overall, it was the use of surveys and interviews, and again, these were on large scale or small scale. But in Unit 2, there was a tendency to be most commonly included is collaboration at network, government department level, more macro. So there's a slight difference between the samples there. So the next thing is that, was there a link between qualitative method and impact made? And I think you could answer this question looking at the percentages, 81%, 93%, yes, there was. I think teasing it out in terms of, as Chris has explained, about the narratives within the case studies, and given the fact that the REF case studies over a series of years of research, linking specifically in a straight line correlation between the qualitative research and a specific impact is quite a challenge, because the impacts are generally described in a narrative against the whole body of research. However, you could make those links. Next slide, please. So I think really importantly, we picked out some examples, and I think these are really, really good examples of how, as many colleagues have mentioned before, qualitative research really does further the understanding of how things work in the real world. An example from Greater Manchester Sexual Health Survey, it undertook 2 qualitative research projects, one in particular about developing HIV literacy, which looked at stigmas actually and homophobia, and how that impacted on people's ability to access and understand HIV and the available knowledge. And this informed how the effective delivery of targeting HIV prevention in particular populations at risk. The green box there was an example of cardiac rehabilitation for patients with heart failure. And this was a model, again, the qualitative aspects of the research within this looked at the experiences, attitudes, beliefs and expectations of patients living with heart failure about how they could see themselves self-managing. And the benefits for this group of patients meant that it went from a very centralised go to the clinic model to a community-based model, and then further off from that, an actual digital online training package, also driven by COVID. On the right-hand side, the purple box there, I think, is a really good example about looking at something that could be seen as extremely subjective in terms of looking at, volunteer and befrienders in end-of-life services and hospices. And I think this particular case studies that were undertaken in-depth interviews with staff in hospices and the befrienders and volunteers enabled best practice to be drawn out, and evidence base for this, and then growth of volunteer roles and toolkits, which then enabled this approach to be broadened out. Next slide, please. So this is one of my favourites, only because the top example there is about really understanding how qualitative studies operate and complement and add depth to in mixed method studies. So this was it was actually on a television series, I think a couple of years ago, but it looked at intergenerational interaction between older people in residence home and 4-year-olds, nursery children, and the combined approach. of the research looked at physiological aspects. So you can see there for the elderly residents, they looked at things like walking speed, grip strength, but actually qualitatively, they looked at their mood, their overall cognitive function, and their memory, episodic memory. Equally, you know, there's some wonderful quotes in this. If you get a chance to look at the case study, definitely look at the quotes. This has switched my brain back on. I now have something to look forward to and think about. So again, the power of some of the quotes, I think, in narratives from people involved in these types of studies is very powerful. Equally, the children, from the observations of the parents in the qualitative research, showed improved confidence, language development, imagination, maturity, empathy, and concentration. So I think it's a really, really powerful example. I think the next one is something about how qualitative research enables a translation into real world. So by 2015, PrEP was already been evidenced to be a fantastic preventative treatment for HIV. However, it had not been implemented at scale and its acceptability in the real world was not known. This piece of research within this case study actually did surveys in a particular group of people who injected drugs in Glasgow right at the point of an outbreak to try to understand what was the acceptability of receiving the PrEP treatment or accessing the PrEP treatment. And this actual case study demonstrated that it directly informed the public health response to the outbreak and actually achieved delivery of that treatment. So huge benefits there. And perhaps would not have been, there'd be no vehicle for that without the qualitative research. Next slide.
I'm very sorry to interrupt you, Dareth. It's fantastic examples. We've not got much time left, so
okay, no worries.
Thank you.
So I'll skip over that slide and go to the next one because that's about translating the work. Now, this one, I'm so pleased that Louise mentioned this in her, focused on this in her presentation because experience-based co-design was a case study that stood out in itself, and it's looking at what are the future applications of qualitative methods. Previously in my career, been involved in transformation programs at scale in large acute hospitals. You begin to see the links with qualitative research and actually undertaking collaborative work with patients and staff in situ to be able to develop real impacts in a very accelerated manner. So I won't say any more about that because I think Louise has covered it. Next slide, please. So in summary then, lots more work, I think, in consideration to think about this, but I think certainly using the REF database search function, we recognise got some flaws in that. I think it's quite hard to identify specific methods because lots of the studies use combined or mixed methods. I think there's some fantastic qualitative case studies within the REF database, and I'm hoping that we'll go on with the team to look at that in more depth. Noticeably, over the time of the REF years, there seemed to be increasing use of PP, involvement of patients and the public and people with lived experience, more use of implementation science and an extension, probably again driven by COVID, in terms of digital approaches to help knowledge mobilisation. So the questions for us, I suppose, to think about is qualitative research which uses and includes implementation science, PDSA, are these going to be more impactful method in the future? And also more feedback perhaps to REF as part of the consultation in terms of the database structure and bid submissions. And I think that concludes. Thank you, Claire.
Thank you, Dareth. That's a really great example of a small pilot study that's generated such a lot of useful information, and you've shared some really great examples. Do go and fill in the survey afterwards, give your email address and we can send you these slides and you can look in more detail at these examples and indeed go and explore the REF database with any other examples that you want to follow up further. Thank you, that was a fantastic overview, a lot of work that you've done there, Dareth, for the team over the summer. So we've not got much time left, but we just want to run those 2 polls if we can, just while we're getting the panel ready for the Q&A. We'll have 10 minutes for questions. Just want to run those 2 polls again. about your confidence in thinking about describing impact from your research. And then we'll put the other poll on about knowledge of impact case studies. So how confident now do you feel about describing impact from your research? And you've heard a great range of talks around influencing policy and practice and evidence-based care, and also what REF means, impact means in terms of REF. So thank you for completing that poll about confidence. Can move on to the. Thank you. I think we've seen a bit of a shift there in terms of levels of confidence. And then the final poll, please, about the knowledge of REF impact case studies. Thank you. Can we have the final poll? Oh, the poll won't launch. Okay, no problem. Don't worry. We can move straight on to the Q&A. So thank you so much to the speakers. You've given us a really great insight into the multiple ways that we can think about impact from qualitative research. So we do have some time for questions. We can looking at the questions that are most popular. We've had the upvoting function, so hopefully we can pass over to Evie and Rachel, who can share some examples of questions, and we can get the panel's perspectives on those. So I'll hand over to Evie first. Could you give us the first question, please, for the panel?
Some great questions in the Q&A. There were quite a few questions related to the sample sizes that qualitative research typically employs. And whether there is a minimum number of participants informing the data, whether qualitative research requires large-scale quantitative research to bring impact. And how can we challenge the narrative of telling stories in a way that are not received as just stories?
Well, fantastic range of questions, really great questions, thank you. I'll first come to Sarah and then on to Louise, if I may. Thank you.
Thank you, great questions, and actually great stuff in the chat, lots of energy. There's lots in there. I don't think that we should necessarily compromise on numbers. Small samples are absolutely fine and they can get us a long way. It won't come as any great surprise that I think relationships are absolutely key here. And you can have some really interesting, really valuable and very legitimate conversations about methods and about where qualitative research can get you and also where it can't get you. And it's absolutely fine to do that. And I think when you build up relationships over time, that conversation changes, and you can that's very, very fruitful. Telling stories was something that I mentioned without much context. Apologies. I think we can use data, much as Louise was describing, to really capture the way that patients experience services, staff experience emotional labour, some of the crisis at the moment, and they can be really, really powerful. But sometimes I've experienced that thrown back to me that it's just stories, it's just something that you've heard. And I think, again, re-emphasising methods, talking about sometimes a bit of theory, the things that can help you, and what makes your work really rigorous and valid and relevant, really all just go to help to reinforce that it's valuable and show how.
You're on mute.
Sorry, that's a fantastic response. Thank you very much. Is there anything, Louise, you'd like to add further to that?
I completely agree that you know, sample size is what the sample size is for that study, and it's not something that we should think that we big up in order to meet quantitative criteria. The question of how you defend stories or narrative data, I quite often use the example of let's say you want to work out whether drug A works better than drug B. you'd be mad to do anything other than a randomized controlled trial. But if what you want to do is understand why people don't take drug A, it's just so obvious that you need something more qualitative. So I use that to defend the method.
Thank you very much. Rachel, can we have the next question, please?
Yeah, so this is a question about co-production from someone who's new to trying to influence policy through qualitative research. They want to know, how do you actually get in the room, as it were, with the people that you need to speak to for co-production? Where's the best place to start?
Fantastic question, thank you. So I'll come to Carolyn first and then to Louise, please.
I think it depends on your question, it depends on your methods. So if you're thinking about people with lived experience and you want to get them in the room, you've got to think about how to recruit them, get them on board. Are you thinking about clinicians? Are you thinking about commissioners? Are you thinking about all of them? And there are different approaches needed for all those stakeholders. Do you want to get them all together? Do you want to talk to them separately? You need to get them involved right at the beginning. So what we shouldn't be doing is doing our study and then saying, oh, we want to co-produce an output video or something. So get them involved right at the beginning. We've just done some work with McPin, who helped us convene a young persons and carers advisory group, and they worked with us right from the beginning, defined the research question, helped us in terms of webinars and things that we held, and have helped us to produce outputs, so a video and some infographics. But the key was treating them as equals and getting them in at the start.
Oh, fantastic advice, thank you, really good example. Is there anything else you'd like to add to that, Louise?
Just like my preferred practice these days is to have policymakers or clinicians or whoever your stakeholder is as co-investigators on the grant.
Yeah, and how, have you got any tips for people about how to, maybe who haven't taken that extra step, how can they best start on that journey of involving policymakers?
These relationships build over a long time. It's not something you can just jump in on overnight. So I guess snuggle up against other co-investigators who've got those relationships.
Great, thank you, really good advice. I think we've probably got time for one more question, so I'll go back to Evie, please.
To what extent does having an established track record of research affect the ability to have impact? Was an interesting question, I thought.
Great question. Krisha, I know you will have seen a lot of examples of case studies, so maybe we can go to Krisha for the ref perspective and then we'll come to Sarah.
Yes.
Thank you.
It doesn't always follow, because I think if we're thinking about, and I'm here to talk about the ref, so if we think about the ref case studies, sometimes it can be really hard to distill out all the impacts from a whole body of research where you've got a lot of established research that's been over decades, to try and actually make a coherent story about the impact that all of that has had can be really hard. Sometimes it's easier if you've got one element of research that is can be really impactful. And I remember in our own institution there was one piece of research that was done about restraints and the use of restraints in young people coming in through the system, going through into a kind of like I suppose if they were taken through on the way for like to a prison or something, and it showed how the actual type of restraint could lead to physical injury, and a small piece of work made a really big difference. And actually it was something that could be implemented, that the approach to restraint could be changed and actually would prevent further injury. So I think that sometimes it can be a small piece of work that isn't necessarily from established researcher, but it's that, you know, it was the right question. And I think the right question that was really needed can be incredibly answered, can be really impactful in terms of the change and the benefits.
Thank you, Krisha. Sarah, can I come to you for a final thought on that, please?
Yeah, I mean, I would echo that. I think it is often people who are perhaps more established who get associated with impact, but it doesn't need to be that way. And I think experience and confidence and relationships all help along the way. Two other things. I think team is really important. I mean, all the things I talked about, and I imagine everybody on this call as well, it's all about the team. And it's a collaborative effort rather than one lone hero trying to seek impact on their own. So get yourself in a good team and recognise and work with somebody who can support you towards that and make sure that you're acknowledged and recognised in that process. And the other thing for me, I mean, I have PhD students who just do amazing work. I mean, some of them are so impactful because they just get the right question. And at the moment on something like climate and health, they are way ahead of us. And so, you know, get yourselves out there. You don't have to be 30 years down the line to be able to do this stuff. You can do it really early on. It's a passion for it, really.
Fantastic reflection. Thank you so much for those insights, the panel, using all of your experience. So hopefully people have been able to hear some great examples of how qualitative research can generate impacts and tips for you now. We know there's so much activity in the chat and in the comments, and what we'll hope to do is have a look at these outside of the webinar and make a report. If you look, keep an eye on the Incubator website, and we'll collate some of this information and these questions, and hopefully you can have access to that over the forthcoming months. I would just like to thank the speakers again for a fantastic session. You've given us some really good food for thought. You've given us some fantastic examples for the community to hear about that hopefully will help them think about how to generate impact and how to describe and generate impact from their research. So thank you to all the speakers, and thank you to the NIHR Academy for helping to run the webinar. Please do fill out the evaluation survey. Tell us what you think. Tell us about your career development needs. Tell us about what will help you in future as a research qualitative methodologist. Thank you very much for your time this afternoon, and I'll now end the webinar. Thank you.